Okay, great. And can you all see the slides okay?
Yeah.
Okay, great. All right, well then we'll just launch into it. So I'm calling this webinar Jumping In because the what we're going to be talking about is really just that. It's how to jump into help with patients who are coming in or who are referred to you as a BHC. Really, no matter what they're coming in for. I mean, and the reason we're talking about this is because to the extent that you guys who are, still settling into your BHC positions are like most every other BHC, you probably have questions about this. You probably have questions about, what kinds of problems are okay for me to engage with as a BHC? What ones should I not be trying to help with? They just feel too severe, too complex, too complicated. But yet, on the other hand, what do we do if patients can't or won't access, specialty mental health for these problems? Then what? I'm not a therapist. I'm a consultant. How do I handle that situation? I mean, these are very common kinds of challenges that people run into when they're doing this work. And a really crucial part of being successful as a BHC is being both willing and able to jump in and try to help with whatever problems the patient's coming in for on that day. Okay, so what we're going to do today is a few things. First, we're going to talk about what are the criteria for referring patients to specialty mental health. Okay, so how do we make that determination about when to suggest specialty mental health to patients? And we're also going to talk about then what do we do in the cases when patients don't go to specialty mental health like we recommended them to. So we'll talk about that. Then we'll get into outlining some basic principles about how to engage with really any problem or any condition in primary care that the patient presents with. And then we're going to have some real world case examples that we'll go through. I've got a few here that we can work through, talk through. But if you may well have your own that you're thinking of as we go through this hour that you want to bring up and talk about. So we can definitely do that then too. We can go through your own case examples. But that's what we're going to do today. That sound okay to everybody? Hopefully, since I've already got the slide deck done. So,
sounds good.
All right, great. And feel free to jump in at any time too, guys. I mean, I do have slides, of course, but really my expectation is just that as you have questions or comments or something, especially, today we don't have a whole ton of slides to get through. I wanted it to be more discussion oriented, and we've got a pretty small group too. So really feel free anytime just to jump in with, stuck points, confusion points, something doesn't make sense, what have you. Okay. All right. So on the first topic here, let's talk through some basic principles about why it's important to engage with patients. Actually, I tell you what, before I do that, I'm going to skip to a case example. I might have even, when we were together previously, I might have even gone over this one, not in any kind of formal way, but I might have mentioned it. I always like to use this case example because I think it's a pretty good one that illustrates how to jump in and help with whatever the patient's coming in for. But let's actually start by going through this case example, and then before we get into discussing the case example, I'm going to go back to some of the didactic slides, okay? So let's just read through it first. And I'll apologize in advance, it's kind of a long case example. It's like 2.5 slides. So Jen is a 52-year-old woman referred for help with weight loss. She reports a long history of challenges managing her weight starting as a teen. She has been to dietitians on 3 occasions and has been in and out of Weight Watchers for the last 10 years. She has at times lost weight over a period of several months, but always gradually regained it. She believes she overeats heavily at meals and frequently snacks on sugary foods. She's married, but reports little affection in the relationship. They have no children. She enjoys her administrative assistant job and gets good feedback from her boss, though she usually worries she's not doing a good job. She has friends who she regularly visits, and they have seen each other through hard times. Jen doesn't get much physical activity. She feels self-conscious of her weight when exercising. She enjoys quiet activities like knitting and crossword puzzles at home. She's always wanted to join a book club, but feels anxious meeting people, partly because of her weight. She reports moderate depressive symptoms. She's not sure why she feels depressed. She just feels down on herself a lot, but feels like she kind of always has. She doesn't smoke, doesn't use alcohol or drugs. She doesn't take any psychiatric medications and doesn't want any. And about 20 minutes into the visit, you notice that Jen appears quite quiet. That should say quiet, not quite quiet, and reflective. She's thinking. Then she says, you asking me all of these questions is making me think of something. I've never told anyone this before, but when I was 10, I was molested by a neighbor man. It was terrible. I've tried to forget about it ever since, but now that I think about it, I think maybe that has something to do with me being heavy. I think I've always believed that if I was heavy, I'd be safe. After all, men won't bother heavy ladies, right? Now, like I said, I don't want to get into discussing this one just yet. We're going to come back to this. But what I want to get into when we do get to this one is, what would you do to help Jen? Okay? Because I'll tell you what happened in the real world with Jen, because this is a real world case example. In the real world, what happened with Jen was everything was going along great in the visit with the BHC. I was training a BHC, actually, a new person. And everything was going along great in her visit up until that point where Jen mentioned that history of sexual abuse. And at that point, everything in the BHC's demeanor and body language and so forth kind of changed. And she had been very engaged with Jen and, getting this great history and everything. And I thought we were headed toward a great result here. And then as soon as Jen mentioned that history of sexual abuse, the BHC kind of looked a little concerned and backed off. Instead of leaning in, she kind of backed off a little bit. And she said, okay, well, that sounds like a really important thing that you mentioned to me. I'm really glad you told me. That kind of trauma is not really something we can deal with here in primary care. I can help you with the eating behaviors and trying to make some changes there. But I think for that trauma, what we should do is we should refer you out to a trauma specialist. I've got some good ideas for you as far as people you could go to. Okay, and the patient had been, just really engaged in the visit up until that point and doing all this reflection. And you could see at that point she kind of lost the patient. The patient was like, oh, okay. Like in the patient's mind, this kind of seemed all connected, but this BHC was kind of drawing a line and saying, I'm not going to be able to jump in and help with that. That's something somebody else is going to help with. And she lost the patient at that point, really, okay? So we'll set that up as a frame because that's what I don't want you guys to do or anybody else. And to that BHC's credit, who I trained, she actually, was able to do quite well with jumping in with future patients and helping. So when you have the patients like that, let's talk about, go back to this previous slide here about how you can jump in and help with them. All right, so what are some basic principles about engaging on these kinds of topics? One is that we can't predict who's going to benefit from what, right? We just unfortunately don't have that ability to know when a patient walks into your office as a BHC if they're going to benefit from your service, if they're not going to benefit from your service, if they're going to benefit best from specialty mental health or something else. We don't know. We don't have any ability to predict that, and to the extent that you think you can predict that, you're wrong. You might have some guesses, right? Like if a patient comes into you with, a lot of, problem list a mile long, they've got, borderline personality disorder in their problem list, history of severe recurrent depression, history of off and on alcohol problems. You might think to yourself, this is somebody who I'm not going to be able to do a lot of help with. I need to get them into specialty care. And you might be right about that, but you might not be right, all right? There are an awful lot of people who go to specialty care who don't get better at all. There are an awful lot of people, by contrast, who get very brief interventions just in primary care, even without a BHC, just with the PCP alone. And they actually do quite well, even when they have complex severe problems. I'm sure you can all think of people who surprised you, right? Who presented to you with some kind of chronic problem. And let's take a simple example of tobacco cessation, okay? Person who comes in, has smoked for 40 years, a pack a day, and isn't sure about wanting to quit right now, sits down, has a talk with you. You do, motivational interviewing kind of intervention, and you think, well, that was nothing. I didn't help that person at all. And you see them a week later in the clinic or a couple weeks later, and they say, hey, you know what? Guess what? I quit. You did? I mean, you're amazed, right? But it happens. And then by contrast, I'm sure you have other people who you thought had kind of mild, moderate problems, acute problems, but they just kind of didn't ever get better. It's dragged on, right? So we can't predict who's going to get better. So you might as well jump in and try to help with all these patients, right? Another basic principle here is that a lot of patients are actually going to respond pretty quickly. Again, we unfortunately don't know who those patients are in advance, but we do know that a lot of patients, a significant portion of patients, depending on the problem, it may be as many as a half to 2/3 of patients will respond very quickly to even brief interventions. Okay. Another fact that we know here, the third point on the slide, is that most patients are not going to complete a referral to specialty mental health. I mean, this is why we're in primary care in the first place, right? Is that there are a lot of patients with significant behavioral issues who either can't or won't go to specialty mental health, or even if they do go to specialty mental health, they won't continue long enough to get any benefit. Or even if they do continue in specialty mental health, they maybe don't get any benefit, right? I mean, so this is the whole reason that we're in primary care to begin with, because there are so many of those patients. So if all we do when we see a complicated, patient is refer them out to specialty mental health and assume that we can kind of then be done with that patient, that's not going to work, okay? Another important background point here is that if we're not jumping in and helping with all of these patients, then what, right? It's the PCP alone with these patients in most cases. I mean, again, you may have, there's a small likelihood that if you refer these patients to the specialty mental health system, that they will actually go and stay in care and benefit from care. And that's a best case scenario. But for so many patients, that's not going to be what happens. And so if you're not jumping in and helping, then we're back to where we started with all of this business in primary care, which is, primary care provider just trying to help these patients alone. And again, that defeats the whole reason that we're in primary care to begin with. And then finally, a last basic principle here about engaging with patients is that, keep in mind, when you are intervening with patients in primary care, you're not doing anything any different than what you would do in specialty mental health, right? I mean, you may be doing it in less time, right? You have less time than you typically do in a specialty mental health visit. And the goals of your visits with the patient and your plans for follow-up may be different and so forth than when you were in specialty mental health. But what you're actually doing with the patient is, I'm gonna guess it's pretty much the same as what you would do if you were in specialty mental health. If you teach a patient the diaphragmatic breathing in primary care, it probably looks pretty much the same to how you taught that patient diaphragmatic breathing in specialty mental health. So, in other words, there's nothing incompatible with this kind of work and using evidence-based interventions. You still can use evidence-based interventions. It's just that you're doing it in a little bit less time here in primary care and with some different goals. So those are just some basic background points here to keep in mind about how and why to jump in with patients. Okay? Any questions before we jump on to the next slide?
No, I think that's good information.
Okay. So, given that then, when do we refer? Because, you may get the impression that I'm saying you should never refer to specialty mental health. And that is absolutely not what I'm saying. I have myself referred probably thousands of patients to specialty mental health. So over the years. So I'm not by any means saying that we should never refer patients to specialty mental health. I'm just saying that when you do refer, don't think of it as an either or, and don't kind of let yourself off the hook for trying to help that patient, as well. So when do we refer? So about a year and a half ago, I wrote an article along with Chris Hunter and Bob Meyer, a couple of the PCBH folks, and as part of this article, we consulted with about 25 of the top PCBH experts around the country, and on various topics related to PCBH. And one of those topics was, what do the experts say about when should we refer patients in this model? Okay, and here's what we came up with. So that's the asterisk here on this slide is kind of referring you to that article, which if you need a copy of it, I can pass it along to you. When should we refer in this model? So there are four kind of situations where we refer in this model. One is when the patient requests a specialty mental health referral. So patient sits down with you for their first visit, you explain what you do, that you have 30-minute visits and so forth, and the patient says, oh, well, that's kind of not what I was expecting. I was really hoping for hour-long visits and somebody I could see every week. I mean, that's what I've done before. So you might say, oh, okay, well, fine. It sounds like your preference then is for a specialty model, and that's totally fine. We can talk today about how you can find that. Okay, so that's one situation. You explain to the patient what you do, and they say, thanks, but no thanks. I want something else. All right. Second referral situation is if the PCP requests specialty mental health. So let's say, and there could be various reasons why the PCP does this, but a common one is patients are on multiple psychiatric medications, and the PCP really feels, unclear or unable to work with those. They want a psychiatrist involved or something like that. There could be other reasons too, but we, as consultants to the primary care provider, our role is really to help them to help their patients. So if the PCP is saying that their plan, what they want to do is they want to refer that patient out to specialty mental health, they don't feel comfortable without that additional help, then fine, that's another situation where we would refer them. A third scenario for referring to specialty mental health is a psychiatric emergency. So the patient is, suicidal, imminently at risk of harm to themselves or others, that kind of a thing. A fourth referral criteria is if they're not improving after a few visits with you. So, let's say that you've been trying to help a patient along with their PCP. You've been trying to help, You've seen them for a few visits. This is your third visit, your fourth visit with them, and they're really going nowhere fast. Their PHQ-9 score has, not moved at all, or it's gone up, or however you're measuring their outcome, it's just, they're not improving at all. That's when you would say, okay, let's get some additional assistance in here. Okay. So those are the main, those are kind of the general situations where we would refer in this model. But if, and an important thing to keep in mind is that if you do refer, you want to continue to provide care to that patient until you're sure that they are engaged with that specialist care, right? Because like we've been talking about all along, I know that that most patients are not going to go to specialty mental health even when you do refer them, or if they go, it's going to be a while before they get in. And so you don't want to just kind of wash your hands of them, consider that you're done when you have referred them and they've accepted that referral. You want to continue to follow them. And when I say continue to follow them, I mean, you want to continue to actually provide care to them, actually providing therapeutic care, trying to help them. A lot of times what I see is once the BHC refers the patient out to specialty mental health and the patient says, okay, yeah, that, I agree, that would be helpful for me, I'll do that. Then the BHC kind of switches into check-in mode, right? So they say, okay, let's follow up in a couple weeks. I want to check to make sure that you've gotten into specialty mental health okay. Patient says, okay. So they don't give them any, the BHC doesn't give them any further interventions to do. They kind of stop working on the interventions, the self-management goals. They set up an appointment for 2 weeks later. Maybe the patient shows, maybe they don't, but let's say they show. The BHC says, okay, great, how's it going with that specialty mental health referral? And the patient says, okay, I didn't go yet, or I made an appointment, it's for, 6 weeks from now. Oh, okay, you made an appointment, great, okay. Well, let's touch base again in a couple weeks, and I want to continue to see you until that 6 weeks is here, right? So in other words, all they're doing is checking in with the patient. For starters, patients often kind of no-show for those appointments because they start to realize you're not doing anything with them anymore. But secondly, I'm sure you've had this happen many times where, patients, just because they say they're going to go to specialty mental health, again, doesn't mean they're going to follow through on it, right? And quite often they don't. In fact, more often than not, they don't. And so if you have not been continuing to help them all along and they don't end up going to that planned specialty mental health appointment, then guess what? Nobody's been helping them throughout all this period, okay? So you want to continue to follow up with patients when you do refer them, and not just check in with them, but actually keep your focus on trying to help make some productive changes with that patient on whatever they were referred to you for. And then finally, if you do refer, it's important to think of that specialist that you refer to as an addition to your care, not a replacement, okay? So this happened, primary care, if you think about what we do in primary care and the goals of primary care, it's about longitudinal care relationships with patients. So it's about, it's birth to death care, as they call it, right? Patients come to the same clinic in many cases for years. And so you're never done in primary care with following patients. They're always your patient. And you as a BHC who is a member of the primary care team, they're always your patient, even if they're going to specialty mental health. So, if just like, if you go in to see your primary care provider because you have a rash and the primary care provider tries to help and is unable to figure it out and they refer you to dermatology, it doesn't mean that they're going to refuse to see you anymore in primary care for any kinds of rashes. That dermatology care is something that they're doing in addition to their primary care that they're going to be continuing to follow you for, okay? So it's an addition to your care rather than a replacement. Don't mistake what I'm saying. Once a patient is engaged with specialty care, if they do go to that appointment, they do get in, they do go, and they, they appear engaged in their care, they're planning to follow up with their therapist, their psychiatrist, what have you, then fine. You don't necessarily need to plan follow-up with them anymore at that point. But all I'm saying is that, understand that even though the patient is engaged in that specialty care, they're going to still potentially, maybe even likely call in at some point in crisis to the primary care clinic. That's something you should, be willing and able to help with, if that happens. They may come into the primary care clinic with a new concern, maybe even something unrelated to what they're seeing their therapist for, and so you might jump in and help with that, okay? So the specialist is an addition to your care when you do it, rather than a replacement. Okay, so we're going to the next slide then, and let's talk here for a few minutes about what do we do, though, when patients don't go or can't go to specialty mental health? Because, every single primary care clinic that I go to, whether they're in the middle of a big city or they're in a remote rural area, it's the same problem. Patients often can't or won't access specialty mental health. So what do we do in that case? Let's say that you've seen a patient for a few visits, they're not improving, you recommend specialty mental health to them, but they don't go. Here are some things that you should do and a thing or two that you should not do. First, the do's. You do want to continue to follow that patient, all right? But when you follow that patient, remember that you are a consultant, right? So that C in BHC stands for Behavioral Health Consultant. And the reason you're a consultant rather than a therapist is because consultants do things different than therapists. One of the things that they do is they follow up differently with patients. A consultant doesn't plan to follow patients all the way until they are, cured or treated to target, whatever your preferred terminology there. What a consultant does is they follow a patient along with the primary care provider just until that patient is starting to improve and there's a clear plan in place for continuing to improve. At that point, their role as a consultant is done, okay? Now, sometimes you get to that point quickly. You might meet with the patient 2 times, 3 times, and you meet those criteria. The patient's starting to make some nice changes. There's a good plan in place that they understand. Everybody understands that they're going to continuing to improve. Perfect. At that point, your job is done at the 2 or 3 visit mark. But other times it takes longer, right? And like I was saying, if you've tried 3 or 4 visits and they're not improving, you're going to refer to specialty mental health. But if they don't go, you are going to continue to follow them, but you're going to continue to follow them with that same follow-up structure. So rather than kind of what some people do is they say, well, I couldn't get them into specialty mental health for therapy, so I guess what I'm going to do is switch into therapy mode myself, and I'm just going to be the therapist myself. And we're going to talk in a minute at the bottom of the slide here about why to not do that, okay? But what I would say, what I would recommend in this model is instead of doing that, continue to follow them, but continue to follow them with those consultant goals in mind. So what does that mean? That means that you're going to continue to follow them, like I said, until they are starting to show signs of improvement and there's a good plan in place. So it may be that you see somebody 7 times, 8 times, 9 times before they finally start to show some good signs of improvement. And they've got that plan in place where they're going to be able to continue working on it, okay, and moving forward. At that point, then, you're done. It might have taken you 9 visits, but you did it, okay? I've had patients I've seen for 20, 30 some visits. Not very many patients, but because most patients don't have that kind of patience, they stop coming in long before that. But I've certainly had some I've seen for that many times before they finally started to show some improvement and there was a good plan in place for them continuing that, and then I backed out of their care, okay? So there's no prohibition or anything in this model on seeing patients for more than, a few visits. It's just that, if you haven't seen any improvement in a few visits, you're going to seek that additional help of specialty mental health and try to get them involved. But like I say, if that doesn't happen, if they don't engage with specialty mental health, you absolutely continue to follow them but only until they are starting to show some good improvement and a good plan is in place for continuing. Okay? The other thing you're going to do, continuing on down the slide here, where it says continue efforts to link with specialty care. So the other thing you're going to do is each time they come back to you after you've recommended that they go to specialty mental health, but they don't go, each time they come back to you instead, you're going to remind them again of your recommendation for them to go to specialty mental health. Okay? Why do you think that's important? Why is it important to remind them each time they come back to see you that, hey, I'm still helping you here, but remember, I do recommend that you go to specialty mental health. I'd like you to still try and do that if you can. Why would we recommend that each time? Any ideas?
This is Leah in Jerome, and I would continue to recommend specialty mental health because there are some people who would just really benefit from going in and seeing somebody weekly to talk to. I mean, it's still super beneficial for some people, and I think I just think it should be part of their continued care.
Okay.
Part of the plan.
Okay. So you've made that recommendation to them that you've noticed that they're not improving even though they've seen you a few times. So you're recommending that they get specialty care. And there's really, I would say, kind of a liability issue here, right? Amongst other things. I mean, one reason you're going to continue to remind them to go is because you do think that may be beneficial for them. But another reason is liability, right? Because you're not doing specialty mental health and you're not intending to do it. You're doing something different. You're doing primary care. So just like any other problem in primary care that isn't improving, if you feel like you're not helping, you're going to try to get the patient to access specialty care. And if they don't go, you want to make sure that you've documented that you've reminded them every visit, right? Because, heaven forbid, if some sort of adverse event happens, a suicide or something like that, they're going to come back to you and they're going to say, why didn't you recommend this person go to specialty mental health? You might have benefited from that rather than your 30-minute visits that you're doing. And, you want to be able to say, I did recommend that patient went to specialty mental health. Every time she came back to see me, I reminded her, please go, please go. She didn't go. Okay. I've got it documented right here. We talk about that each time. So you do want to continue your efforts to help, but you don't want to. You want to make sure that you document that too. But you don't want that to come at the expense of you continuing to help. So, okay, good. Last thing you do want to do is you do want to continue to work on improving functioning. Like I was saying, you don't want to fall into just kind of check-in mode with the patient. Okay, you're still here, good. Don't forget, you should go to specialty mental health. See you in 2 weeks, okay? Don't fall into that mode. Continue trying to work on improving their functioning. What you should not do, though, is like I was saying earlier, what you should not do is fall into that therapist role, okay? Now, why do I say that? Why do I say don't fall into that therapist role? There are a few reasons, really. One is, if you do that for every patient who doesn't go to specialty mental health, then guess what? Your schedule is going to start to fill up with these therapy clients. And your role is quickly going to start to get very confusing here, not only to you, but also to patients, to the primary care providers, to the billing people, right? And access to you is going to start to clog up. Okay. The whole reason that we see patients in a consultant model and for 30-minute visits is because we're trying to be as available as possible to see as many patients as possible, be as helpful as possible in the moment. The more patients you're seeing for hour-long visits and seeing them back, for over and over for long periods of time, the fewer patients you're going to be available to help. So your access starts to be sacrificed. You can run into legal or insurance problems if you're on the one hand saying you're not practicing specialty mental health and you're billing one way. On the other hand, you are practicing specialty mental health and you're billing this way. It can get very confusing sometimes with the rules and regulations in the billing. And it's just going to be, like I said, confusing to the patient and to the team too. For example, you tell the team, I'm highly interruptible. I'm a consultant. I'm available when you need me. Interrupt my visits, even if I'm in with the patient. Does that still apply if you're doing therapy with the patient? Because typically therapists have a different kind of expectations for their role that is assumed and implied when you are doing therapy and billing therapy. So should you still be interruptible when you're doing therapy? And is that really, ethical, right? It works for this kind of team-based consultant care that we're doing, but I'm not sure if it works if you're doing therapy with patients. So it can all get to be very messy. And the reality of it is you don't need to do that, right? You can continue to practice as in that consultant role, like I was saying, just as you would otherwise, following the principles I was laying out above. Okay, last thing here, last slide, and then we're going to get into a case example or two with the remainder of our time. So let's talk for a minute here, a few minutes on this slide about the clinical aspect of jumping in and helping with any problem. There are a few kind of key assumptions about the nature of your work, about the nature of behavior change in patients that are really important, really helpful to have if you're going to jump in and help with whatever a patient's coming in for. One helpful assumption is that what we call disorders, right? So substance use disorder, depressive disorder, personality disorder, what we call disorders are really maladaptive behaviors, okay? They're not diseases that we catch by being sneezed on. They're disorders that are a collection of maladaptive behaviors, and those maladaptive behaviors are learned, which means they can be unlearned, by the way, or new, more adaptive behaviors can be learned. So they're maladaptive behaviors that have been learned and maintained by various external and internal factors. External factors might be like things going on in the person's environment, right? Like if you're trying to, if you've learned to drink alcohol when you're feeling stressed, then an external factor that might kind of contribute to that is people in your environment offering you alcohol when you're feeling stressed. An example of an internal factor might be how you are thinking about things, right? Like you're thinking, I don't want to deal with this stressful problem, so I'm going to not think about it, and I'm going to think about just enjoying my beer instead. Okay, so maladaptive behaviors are learned. They're maintained by various external and internal factors. And many maladaptive behaviors occur as a result of skill deficits. So, maybe the reason that you are drinking in response to stress is because you never really learned what else to do when you are stressed instead of drinking, right? You're not sure how else to cope with that stress. It's a skill deficit. And then lastly, direct behavior change is the most powerful form of human learning. There has been debate over the years, right, about if you can change the way that you think, it can change the way that you behave. And that is probably true. But there's more evidence more recently that it's more the reverse is true, that if you can change what you are doing in the world, change your behavior, that will help change your thinking and your emotions. So what does that mean for us? What does all this mean for us? It means a few things. One is it means don't be intimidated if you see a problem list a mile long with this disorder, that disorder, that disorder, that disorder. Just remember, those are all collections of maladaptive behaviors that have been learned, and there may well be more adaptive behaviors that you can help that person to learn over time that are going to be more helpful to them. All right? And if you're going to try to do that, the best place to start is probably with trying to find some direct behavior changes that the patient can start making. All right. So what is that? So in terms of interventions for us, that often means like finding exposure strategies for a patient to do who's very avoidant, trying to avoid bad feelings, or doing behavioral activation with patients, or setting self-management goals with patients. If you can work with patients on those kinds of direct behavior changes, those are often the most effective and the fastest ways to get at changes with patients. There was actually a study that came out a few years ago, I guess, that showed that for behavioral health consultants, they looked at a whole wide range of interventions, cognitive interventions, relaxation techniques, exposure strategies, behavioral activation, a whole bunch of others. And what they found is that when the BHCs used exposure or behavioral activation, those patients improved the fastest compared to patients that where the BHC was doing like a cognitive restructuring or something like that. Okay, not to say that you should never do cognitive restructuring with patients, or you should never do relaxation techniques with patients. I don't mean that at all. Sometimes it's very, very appropriate to do that. But if there are opportunities to work directly with changing behaviors in the patient, that's going to be your best bet for starters. Okay? Okay. So with our last, 15 minutes or so, we'll go through some of these case examples. But we'll start with Jen, who I read at the very beginning of our time here. But before I get into that, questions, comments about this background material?
Yes, I have a question. Okay. Are you muted, or are we?
No, we're unmuted.
Okay, so I have a question, because when you
Sure.
say behavioral activation, I just want some clarification on what you mean by that term.
Oh, excellent question. Thank you. Behavioral activation refers to it's a specific technique. And when I explain it, you're going to say, well, I do that every day. So it's kind of academic term, I suppose, for a particular type of intervention that is most often done with depressed patients. If you think about what you see happen a lot in patients who are depressed, they become much less active in activities that they previously were more active in. Maybe they stop exercising as much as they used to. Their physical activity goes down. Maybe their social activity goes down. They stop hanging out with friends or family as much as they used to. Maybe their recreational activity goes down. They stop engaging in that hobby that they used to really enjoy and do every week. So they become deactivated, in other words, is the term for that. And what we know about depression is that when a person does that, when their activity level when they're already feeling depressed to begin with, and then their activity level drops like that, they tend to become more depressed, right? Because when you're less active, then you have more time to think about problems. You get down on yourself for not doing those things that you used to do, so you start another thing to beat yourself up about. You miss out on the positive experiences that come from doing those activities. So all of that in turn then makes a person more depressed, and then more, or less likely to be active, and it's this big cycle that gets created. And so what behavioral activation refers to is it's when you explain that cycle to patients, and then you set specific goals with them for re-engaging in some of those activities. So maybe they set a goal for getting back into their exercise. You know, they agree to go back on walks 2 times a week for half an hour or something, or they agree to meet up with their friends, you know, at least once over the next 2 weeks, you know, instead of avoiding their friends, that kind of thing. So you're getting them more active in these activities that they've dropped out of. That's behavioral activation. Does that answer the question?
Yes, it sure does. Thank you.
Yeah. And that behavioral activation, just that alone, has been shown many times over in many studies to be a frontline, very effective treatment for depression. So.
And Jeff, this is Tori. I guess I'm excited for just overall this presentation, because I think, you know, in this year, as we've expanded the program and tried to get some of these things set, we have some components, like we're almost close to getting a registry for those patients who've been referred to specialty, so we can follow up with them. You know, if you see a patient for more than 4 to 5 sessions, I'm kind of loose on that, but to let me know so we can case the patient and that kind of stuff. But I think on the same note, I was missing some key concepts and descriptions that you've given in this presentation on how it all comes together.
Good. Yeah. And I'm so glad, Tori, that you wanted to, start with this topic as a webinar, because this is such a stuck point, I think, for a lot of people when they're practicing in this model. And so I think and yet at the same time, if it's something you can move past, this is where you really get into the most challenging, yes, but the most fun, the most rewarding, the most helpful kinds of PCBH service. What is not a fun, challenging, rewarding, helpful PCBH service is just telling patients, that seems pretty complex for my 30-minute visits. I don't think I'm going to be able to help you. I better refer you out. That's usually not satisfying nor rewarding for anybody, nor helpful. So again, not to say you should never refer out, but it's totally fine to do that as under the circumstances we've talked about. But it's about how you conceptualize that referral out, and it's about how you continue to engage with that patient even along the way, even as you may have referred them out, until they're firmly entrenched in that specialty care. Yeah. Case example.
I'm sorry, Jeff, we didn't hear that last little bit.
Oh, I was just asking if there were other thoughts or questions, or should we just go to the case example? Can you hear me?
I think we're good. Yep, I think we're good here.
Okay, great. Let's revisit with our last 10 minutes here. Let's revisit this case example, and then if we have time, we'll go through a second case example too. I put a few in here just because I wasn't sure how much time we'd have, but don't need to go through all of them. Okay, let's read it again. So Jen is a 52-year-old woman referred for help with weight loss. She reports a long history of challenges managing her weight, starting as a teen. She's been to dietitians on 3 occasions and has been in and out of Weight Watchers for the last 10 years. She has at times lost weight over a period of several months, but always gradually regained it. She believes she overeats heavily at meals and frequently snacks on sugary foods. She's married, but reports affection in the relationship. They have no kids. She enjoys her administrative assistant job and gets good feedback from her boss, though she usually worries she's not doing a good job. She has friends who she regularly visits, and they've seen each other through hard times. Jen doesn't get much physical activity. She feels self-conscious of her weight when exercising. She enjoys quiet activities like knitting and crossword puzzles at home. She's always wanted to join a book club, but feels anxious meeting people, partly because of her weight. She reports moderate depressive symptoms. She's not sure why she feels depressed. She just feels down on herself a lot and always has. She doesn't smoke or use alcohol or drugs. She doesn't take meds or want any. About 20 minutes into the visit, you notice she appears quiet and reflective. She's thinking. And she says, you asking me all these questions is making me think of something. I've never told anyone this before, but when I was 10, I was molested by a neighbor man. It was terrible. I've tried to forget about it ever since. But now that I think about it, I think maybe that has something to do with me being heavy. I think I've always believed that if I was heavy, I'd be safe. After all, men won't bother heavy ladies, right? So, the question for you all is, what would you do to help Jen? And referring her out to work on that trauma is not included in the options here. What would you do to help Jen?
Are we unmuted right now?
Yep.
Okay. So I think this is super relevant because people reveal to me all the time that they have been sexually abused and they've never told anyone else. So
exactly.
This comes up for me quite frequently.
Yep.
And so I always, I'm always empathetic, and I say, wow, that's huge that you just came out with that. I ask them, do you want to tell me a little bit more about that? And then I'll ask them, like, what do you know about the long-term effects of childhood trauma? And then I'll try and do a little bit of education about what trauma can do to a person. And I try not to overwhelm. I try to keep it simple, but I let them know that childhood trauma, we definitely take it with us into our adult lives. And it very, very much can be impactful with what they're going through right now.
So you would do, okay, good. So you would do, it sounds like what you do is some maybe, psychoeducation, I would call it, but also maybe kind of normalizing.
Yeah.
Yeah, okay. Which is good. Yeah. So, and that is absolutely something you could do with this person. Reinforce, she's already kind of started to connect the dots now during this visit. She's already kind of started to connect the dots between that past trauma and some of her current behavior. So she's figured out some of it on her own, and there would be a role for you kind of reinforcing that, right, with that education that you're talking about. Okay, good. And then what would you do?
Well, I always like to see where they go with the information I give them.
Mm-hmm.
Like you never know where it's going to go.
Very true.
I give them a little bit of information and normalize, like you said, and then see how much they can handle. Are they super interested? Are they really freaking out? Like, how far do we want to go here?
Mm-hmm.
So,
if I may.
I'm sorry, go ahead.
I'm Cynthia from the Twin Falls Clinic,
Yeah.
the BHC. So in addition to what you and Leah are talking about, and since you said up front, you're not allowed to say at this moment, don't say the referral to therapy, I would ask her what her goal was today and what she wanted to work on in changing behaviorally what she's identified as the connecting the dots from the childhood sexual abuse to her weight, and ask her if that was a behavior area that she would want to work on.
Yeah, she was referred. So when we go back to the first slide here, she was referred for help with weight loss. So she's this came up, during her visit with the PCP. If I remember correctly, she was having some at risk, like pre-diabetic, I think, something like that. The PCP really, wanted her to make some changes with her eating and exercise, and she was interested in trying that. So that's how she came in the first place.
Right.
If you take a look at some of the characteristics here of her history, let's see what stands out. I'm back on the first slide here. Let's see what stands out about how she is coping with things. One is that she gets down on herself a lot. You notice that? Like, she's doing well in her administrative assistant job. She gets good feedback from her boss, but she usually worries she's not doing a good job. If we go to the next slide, she feels self-conscious of her weight when she's exercising, so she kind of avoids exercising. She wanted to join a book club for a long time, but feels anxious about what people would think about her, and so hasn't done that. She feels depressed and down on herself a lot. Okay, so that's one kind of pattern I'm noticing here. Another pattern I'm noticing is that she's a bit avoidant, right? So she is, let's see, mostly avoidance comes out on the second slide, I think here. She's avoiding exercising, again, because of those fears. She's kind of avoiding going out of the home much, like her life revolves around these quiet activities. Nothing wrong with that if that's your preference, but I kind of get the sense she's more, it's not that she is over the moon about knitting and crossword puzzles. She's got other things she wants to do, like exercise, go to the gym, go to the book club, but she's not doing that. She's mostly staying home, okay? So she's a bit avoidant, and she's kind of getting down on herself a lot. Do you guys see those patterns there? That makes sense to you?
Yeah.
Yep. So what might you do then in the couple minutes we have left here? If you've recognized that pattern in her, you've recognized that she's a bit avoidant, you've recognized that she's kind of getting down on herself a lot. She's also just had this revelation that all these years she's been thinking that if she made herself heavy, she'd be safe, and she's kind of realizing that belief isn't necessarily correct. She's starting to question that. That give you any ideas about any interventions you might be able to do with her?
Well, I might ask her what is one small thing that she'd like to try this week, an experiment that she'd like to try, to something she's wanted to do but has stopped herself from doing.
Okay, absolutely. I think that would be an excellent thing to do. I would probably explain to her a little bit, first about why I was giving that recommendation. I would probably say, one thing I noticed is you have a number of things that you really, would like to be doing, but you're not doing them. A lot of it because of anxiety, and that happens when people are anxious, right? They avoid situations because of what they fear might happen. But I'd be curious to see what would happen if you did try some of these activities, right? So I might set it up a little bit that way, right? Some education, and then do exactly what you were saying, right? See if we could come up with an activity for her to do. And then the other thing that you might do is around those, distorted thinking. She herself has already started to, like I say, put together that she's got some distorted beliefs there. So I would probably really reinforce that and say, wow, fantastic job putting that together, that how that trauma is affecting you today. And, I think we should use this new revelation here, okay? How about each time that you feel inclined to eat something that you tell me back here at the beginning that that you're eating a lot of sugary snacks, and you know that you overeat heavily at times. How about if moving forward here over these next couple of weeks we try something where when you notice yourself wanting that sugary snack, or you notice yourself wanting the seconds at meals, that you're instead going to ask yourself, what am I thinking? And you're going to you're going to look for that old thought that if I eat this, I'm going to be safe. And you're going to maybe try to practice a more helpful, more accurate, true thought instead. How about if we try that, right? So I might give the patient an assignment where I make use of this revelation that she's had there that day. That make sense?
Yeah, that's a good one.
I have the advantage of being able to think about this ahead of time. So
yeah.
Well, good. I know we're at time here, so I'll let you all go. But thanks so much for your input. We got a couple other webinars, so if we need to talk more about this, we certainly can. But we'll be in touch about all that moving forward.
Thank you. Thanks, Jeff.
Okay.
Thanks, Jeff. And I'm going to stop the recording now.
All righty.